So good morning, everybody.
Yeah.
Good morning, Professor Shah.
Yes.
So shall I start sharing my screen?
Yes.
Okay.
Today we'll have a OSCE presentation on hepatobiliary pancreas. Professor Dr. Sanjay Debokshi is a very eminent teacher amongst us. So we had very good OSCE scenarios. So our PGs will answer the question, and at the end, Dr. Debokshi will also summarize. So Dr. Debokshi, please start.
Thank you. I'll turn my video off so that there's no bandwidth problem. Is that all right?
Okay, no problem, sir. No problem.
Can you still see my full screen?
Yes.
Okay. So I start off with the first OSCE. Who's going to be taking on?
Maybe Milind?
I'll start. Sir. Should
Sorry.
I read?
Yes, please.
A 43-year-old male presents with a history of waxing and waning jaundice with pain, neglected and treated with homeopathy. Recently, the jaundice has become constant and progressive. The MRCP is present. What does it show? This MRCP shows dilated. So if you start from the top, dilated IHBRs along with dilated along with dilated CBD, slightly dilated MPD, and so there appears to be some kind of a filling defect or a growth at the very base of the CBD, sir.
Try to see. There is a classical appearance of this distal end of filling defect. This is a classical description of a filling defect.
Can you see it ends in a claw? It's a claw-like thing.
Yes, sir. Yes.
So if it's a claw-like thing, that is what Professor Shah is saying. This is a classic filling defect. This is, if you had a growth out there, it would have shown a shouldering, isn't it?
Okay, sir.
This is a classic crescentic filling defect. You see, there are two sides which is going like a crescent.
Yes, sir.
This is classic of what? Lesion.
Sir, CBD stone?
Yes.
Yes, impacted CBD stone at the lower end.
Okay,
Yes.
sir.
You're absolutely right. So what? So now that we've answered the first two, preoperative ERCP could not go beyond the lesion and failed.
Yes, sir.
At the operation, the lesion could not be handled by laparoscopic bile duct exploration. So how are you going to manage this condition?
Patient on table. Lab has failed.
So then we, sir,
That has failed.
so if the laparoscopic CBD exploration could not be done, sir, I would like to proceed with an open CBD exploration, sir.
That means conversion.
Convert, yes, sir. Convert.
That means conversion.
Yes, sir.
So what will you do if you convert?
Sir, in that case, with the sir,
Impacted stone at Ampala cannot be manipulated up. You cannot remove the stone by using Desjardins. What next can be done?
What next can be done?
So we can try to remove it. We can try to insert a small catheter and try to remove it dislodge it with the help of water pressure.
It's impacted. Milind, that's completely impacted. The catheter cannot go beyond that. That's what the ERCP tried. They tried to get there.
A small ureteroscope is tried sometimes, sir, or a Domian basket to take it out.
Everything from above has failed. You have done a coldocotomy, you cannot remove the stone. So what else can be an alternative to remove the stone? During open surgery, there is another technique apart from doing a coldocotomy above. Stone impacted the ampala in the sphincter.
Sir, an approach from below, sir, but as I am not.
Below means what?
How do you? Yes.
So
What
we
do you
go.
do below?
So we go
Okay.
from the duodenum. We go from the duodenum, sir. Basically.
So you do a
So
duodenotomy
what is that procedure called?
and then find the sphincter. So what is how do you identify the sphincter? Where is the sphincter? The ampulla. If you open the duodenum, where
Yes,
do
the
you
second
find
part of
this?
the duodenum, sir.
Where? Second
Sir,
part where? In the
At
posterior
the
medial wall.
junction of the,
posteriorly, sir.
yes, posterior medial wall. So therefore, see, I mean, the modern technology, if you have to evidence-based, you can use an Nd:YAG laser. The Nd:YAG laser is wonderful because it has low penetration. So it doesn't have penetration, and it shatters the stone. So that is one of the modern techniques that can be used. You've done a choledochotomy and you can do it. The other thing that could have been done by the medical gastroenterologist is to use a slim tipless basket. You can't use a basket with a tip because that damages the mucosa. So a tipless the domia, usual domia basket can damage the mucosa. And as Professor Shah quite rightly said, transduodenal sphincteroplasty. Now, usually it is traditional to put in a longitudinal cut. Why a longitudinal cut, Melin? Why not a transverse? Because you have to close it transversely.
Transversely. Yes, sir. The Heineken Miculus principle, sir. We close it transversely. Hello?
Yes, but why? Yes, to avoid narrowing of the
Narrowing
duodenum.
stricture, sir.
But
We to avoid stricturing at that point.
so why don't we put in a transverse incision?
So because uh,
Because it's sometimes very difficult to identify the ampulla. If you put in a transverse incision, you might, I mean, first step is a cauterization. Then even if you put in a transverse incision, sometimes it's extremely difficult to identify uh, the ampulla. So which is why a longitudinal incision is used, and you close it like this transversely. Once you've opened up, the usual technique is you cut on the ampulla and you keep on stitching, take on bites. The moment you extend the bites, sometimes you have a chance of opening up the posterior wall of the duodenum. And that is a disaster that you need to avoid. The
okay,
other incision that can sometimes be used is something called a lazy S incision. A lazy S incision is half horizontal, half longitudinal. You see, that's the lazy S incision. So, that can be closed with ideally with an interrupted extramucosal stitches. Any other
Yes. You see,
questions?
if you take the clock in the sphincter, where do you make the opening in the sphincter? Where do you make the sphincterotomy? At what o'clock?
Yes, good question.
This is the area between 10 o'clock to 2 o'clock is really
Yes.
digital avascular area.
Yes, sir.
And
10 o'clock.
then you do the sphincterotomy at the 12 o'clock position.
Yes, sir.
How far will go? If you keep on cutting the sphincter along with the duodenal wall, what should be the limit of sphincterotomy? Because otherwise, if you go beyond, it will open up the duodenum. We don't want to open the duodenum. We just want to open the
Sphincter.
ampulla. How far? What is the limit of
How far?
sphincterotomy?
Sir, 5 mm, sir. I think less than 5
No,
mm.
5 is too less. You can safely do a 1 centimeter. You can go at best up to 1.5, not beyond that. If you go beyond 1.5,
Never beyond that. Yeah, because it then induces a posterior leak from the duodenum. Okay, there's sometimes a sort of a transverse hood, and people have occasionally called it the monk's hood. You don't try and not go beyond that because there are blood vessels out there, and the duodenum has a chance of perforating, which is why you take a bite. The moment you take a cut, you take progressive bites as you open up the sphincter. That's how a transduodenal sphincteroplasty is carried out.
Yeah.
Okay.
So each question will bear marks. So each question will bear marks. The question will be like that only. Okay.
Sir, I have a
Right.
question.
Yes, Malvika.
Yes.
Sir, for the last question, if we answered choledochoduodenostomy, would that be appropriate answer.
No.
No.
It's not colloidal. It's an impacted stone in the ampulla. Try to understand. You cannot remove the stone from above. The stone is
Okay.
impacted. So in that case, you have to open up the sphincter. If you open up the sphincter, do a sphincteroplasty, that is as good as a drainage. You do not do a colon. Suppose you have failed with all measures. You cannot remove the stone. Stone is impacted. They have no way out. You failed in all respect. In that case, you can do a bypass, but still the stone impacted will cause some problems. Okay. The best way to manage is a transdural sphincteroplasty.
Okay.
The other problem is if you leave the stone, as Professor Shah said, Malavika, the stone sometimes grows in size and then you have a duodenal blockage. Okay, sometimes that is possible. So you've done a choledochordiagnostomy out here. Milind, I can't annotate, but that's all right. If you have a large stone out here, it sometimes blocks the duodenum, and that's called that has a very unusual. It's a very unusual symptom. It's called a Bouvere's syndrome. Bouverep''S. Bouvere's syndrome. Okay, so which is why you don't want to do it. You tend to leave a sump out here, which gets infected. All the food material goes in, and then you have something called a sump. SUMP. Sump syndrome. Isn't that right, Professor Shah?
Yes.
Okay, sir. Thank you.
Malvika, you take the next question.
Okay, sir.
Okay.
Okay, I'm going to show you a video graph. Professor Shah, this is an unusual case. It's a very rare case, but it was presented. This was one of the cases presented in last year's TISA final. So, which is why I thought it was important. So, Malavika, do you want to take this? I'm going to show you the video graph. Read it through.
26-year-old presents with right upper quadrant pain and progressive obstructive jaundice, presenting gradually over the last 3 months. A video grab of his CT scan is presented.
The video.
So I'm going to run the video. That's the thing that I'm trying to point out. I'm going to run it again. You can see the dilated bile duct, but the important thing is when you come down below that.
Okay.
So what do you think that is being shown, Malavika?
So I'm not sure.
Follow the
transversely. Try to see.
Right down to the end.
This shadow was running transversely.
There's a black shadow. What is this black shadow? What does black indicate?
Transversely. In front of that.
Usually indicates as duodenum. The duodenum.
No. It's running transversely. Try to see. In front of IVC and aorta, something running transversely is what is the normal structure there?
The duodenum, sir.
No. See the bile duct. And then something is no. What is it? Broad structure in front of the vessels. No. How can esophagus come down there?
Just I've kept my cursor out there.
Yeah.
See, the bile duct is narrowing.
Yes.
And then you have a transverse structure filled with gas in front. I think, Professor Shah, this is a very rare condition. So shall I give the answer?
Yes.
So this is a condition called Lemel syndrome. Unfortunately, I didn't want to do it, but last year, TISA final, the finalist had this to contend with. Professor Santosh John Abraham gave that. So it's an obstruction at the ampulla due to a duodenal diverticulum, and the treatment usually is an endoscopic extraction of the collected food material or an extracorporeal shockwave to break down the infiltrated food material. And if nothing can be done, a surgical diverticulectomy. I think Professor Shah, Malavika can stay on for the next one.
Yeah.
This was a...
Yes.
Should I read it?
Yes, you read.
A 46-year-old patient from the Far East presenting Presently living and working in India, presents with recurrent attacks of right upper quadrant pain, obstructive jaundice, and hectic spikes of fever. The MRCP is presented. The MRCP shows grossly dilated intrahepatic as well as extrahepatic biliary fluid.
How far?
Is it uniformly dilated?
No,
I
sir.
mean, that part is dilated. This
Yes.
part and that part. So is
The
it
proximal
uniformly
CBD
dilated?
No, sir. The proximal CBD is it's irregularly dilated. Proximal CBD is more dilated than the distal side.
So this patient is somebody from the far east. There is a reason for my putting that. So what is your diagnosis? He has been having this recurrent attacks. She has been rather having this recurrent attacks of right upper quadrant pain, obstructive jaundice, and hectic spikes of fever for the last 8 months.
So obstructive jaundice due to the Chinese liver flu.
Sorry?
Obstructive jaundice because of Chinese liver flu.
No.
No, this is a condition. This is a very condition that affects we from Asia. That's actually a recurrent pyogenic cholangitis. The etiology is not well defined, but some people think it might have something to do with malnutrition, where you have one of the deficiencies of the enzymes that inhibit deconjugation of conjugated bilirubin, so that you have pigment stones forming in the bile ducts. You know, you sometimes have stones that might be a stone. You can see that there's a bit of a darker shadow out there and out there. So it might be stones forming. Okay. You have brown pigment stones, which is why the treatment, and you're quite right. I mean, parasitic infection with Ascariasis, Clonorchis sinensis, and the other liver fluke, Opisthocoris, can cause this condition. So, important thing, because it's a pigment stone, ursodeoxycholic acid has no action. So the options are basically interventional ERCP stone extraction and endobiliary stents, or interventional radiology. At surgery, you do an exploration for the common bile duct for stone extraction. Sometimes here you do a bilioenteral bypass, and you often need something called an access loop. What is an access loop, Malavika?
I don't know.
Okay, when you do, I can't annotate out here, but basically what you do is you do a hepatico-jejunostomy Roux-en-Y. So the options really are, when you have, nobody can do a drawing out here. No, I can't do a drawing. The options really are, hang on, I can actually, sorry. So you bring the jejunum up out here. That's the end of the jejunum. And then what you do is, instead of ending it out here, you bring this part in just subcutaneously to under the skin, so that you anticipate for recurrent blockage, so that the gastroenterologist can go in and do it. The other option is to join this end to the
stomach. Yeah.
So that you don't have an option. The patient doesn't need an operation. So at endoscopy, you go in and explore this, your choledocho enterostomy, and then you can dilate and extract these stones. So that is what you can do. That's called an access loop. And sometimes, like this patient out here has a reasonably normal, no, he doesn't, he has a dilated left duct system. Let's suppose some of these patients actually come in with a huge dilatation of the left ducts and the right duct is normal. There you might actually consider doing a left hepatectomy and doing an anastomosis out here. And where absolutely nothing can be done and patient is progressing to secondary biliary cirrhosis, so you might want to consider orthotopic liver transplant. Okay. Next. Who's next? Who's going to be presenting next?
Mitesh, you take over. Mitesh.
Yes, sir. An infant aged 6 weeks is brought to you. The parents complain he is turning a progressive yellow They were initially told that this was physiological jaundice and treatment with phototherapy did not work. Examination shows a deeply jaundiced infant with hepatosplenomegaly, no other congenital abnormality. The ultrasound scan image is presented. What is shown on the ultrasound scan? What is your diagnosis? How would you proceed to establish the diagnosis? How is the condition classified and treated? Sir, ultrasound sir, shows sir, dilated CVD is dilated,
See
sir.
the intrahepatic biliary
To
radius.
show you, if you were doing if for example, you were doing a Doppler,
Yes, sir.
this is the sort of things that you would find.
Uh,
This is the sort of finding that you would see. You've combined now an echo Doppler with this. So that is
yes.
actually not the bile duct. That is your portal vein. Can you see this? Can you see this whitish structure on top? Look at the
Yes, sir.
infant. What do you think? What do you think that the infant has?
It is not physiological jaundice. Jaundice at birth is most commonly due to what? It's not physiological. And jaundice is progressing.
Hepatobiliary tracing.
Yes.
So what is your diagnosis?
Yeah, you said correctly. Say it again.
Sir,
Say it
extrahepatic.
loudly.
Sir, extrahepatic biliary atresia.
How can you say it's extrahepatic? I'm just asking you. How do you say it's extrahepatic? If you had extrahepatic, you would have a very large dilatations of the intrahepatic biliary tree, isn't it?
Yes, sir.
So it's very difficult. So you're absolutely right. So your diagnosis is biliary atresia. I would stick to biliary atresia. How would you proceed to establish the diagnosis? So I'll give you the answers. You see, what happens is that the bile duct forms a solid cone. And that is the thing that you're seeing out here in front of the portal vein, right? It's a triangular
Yes.
cone-shaped fibrous ductal remnant, which is drawn in green. It's represented by a dense white fibrotic band on ultrasound scan just above the right portal vein before its bifurcation. Sometimes a small GB can also be seen, right? So
Yes.
how do you classify this? So, biliary atresia is global occlusive cholangiopathy. Then there are three types: type 1, type 2, type 3. Type 1 is where the GB contains bile, and you see that as you quite rightly mentioned, there's a bit of an intrahepatic presence of biliary tree. So degree of preservation of intrahepatic bile ducts. So that is about 5%. In 2%, visible, you can't see the gallbladder, but you see visible patent ducts at the porta. And type 3, that is the worst, but unfortunately, that's the maximum. You have GB solid mucosal, solid porta, and microscopic ductule. So which is why don't ever start off by saying it's an extrahepatic biliary atresia. Okay, your answer
Yes.
should be a biliary atresia because you need to find out whether it's dilated. So this is the variant which is more than 90%. You can see this combined is 7% and this is more than 90%. So that is the problem of biliary atresia. And you have a heterogeneous etiology. Sometimes you have a syndrome called the biliary atresia splenic malformation syndrome. It has a first trimester onset and it has polysplenia. Mother usually has diabetes, asplenia, situs inversus, preduodenal portal vein, multiple defects, situs inversus, which is why we said that the patient didn't have any other congenital malformation. So given a biliary atresia, it's important clinically to ensure that the child doesn't have other congenital malformations. Cystic biliary atresia, first or second trimester onset, often isolated, and what you were trying to mention, isolated extrahepatic biliary atresia may have an underlying viral etiology. Usually do a blood, rarely more than 15 milligram, moderate rate of SGOT, SGPT, but a very high rise of gamma GT with a normal protein and albumin. These are the differential diagnosis: Torch syndrome, alpha-1 antitrypsin, Alagille syndrome, and cystic fibrosis. Usually the ultrasound scan is enough. You have a triangular cord sign. That's the one that we showed you. That's a triangular cord sign. In front of bifurcational port vein, radioisotope imaging, HEDA scan can be done. Cholangiogram, BRCP, percutaneous transhepatic puncture of GD for sampling and dye test, liver biopsy, or transhepatic laparoscopy. Now, how are you going to manage this patient? Let's suppose this patient has small ducts in the intrahepatic biliary channel, in the liver. So how are you going to manage this?
It can be a two-stage procedure also sometimes.
Yes.
A single stage.
Sir,
What is Kasai operation?
yes, sir. Yes, I said.
What is it? Okay, I'll show you. I mean, traditional, you follow the umbilical vein. It's your anatomic landmark. The umbilical vein always drains into the left portal vein. Okay, so you go and find the biliary remnant out here. Okay, and then what you do is you do a complete excision of the portal plate. This is a transected portal plate, and then you can do a jejunostomy, a Roux-en-Y porto-jejunal anastomosis.
Yes.
Professor Shah, do you want to comment on anything, the two-stage procedure?
Yeah. This is sometime you may not have hepatobiliary radicals, but intrahepatic might be patent. In that case, this may work. But most of the time, it is a bailout procedure. You do this, let the child improve to some extent, and then the final treatment is what?
Sir,
What is the final treatment?
sir, liver transplantation, sir.
Yes. Orthotopic liver transplantation, absolutely right. So indications, NSAID, Professor Shah quite rightly said, end-stage liver disease, usually following a Kasai portoenterostomy, but less commonly as a primary procedure. It's exactly what Professor Shah said. This is the bridge, two-stage procedure. Cholangitis is recurrent despite prolonged intravenous antibiotics, and the traditional evidence base is you do the surgery before 8 weeks. If you waited longer than 8 weeks, this child has progressive liver damage. There is severe portal hypertension, hepatopulmonary syndrome, evidence of malignant change, and failure to thrive despite maximal medical intervention. So these are the indications for a liver transplant in a biliary atresia. Okay.
Yes, sir.
Mr. Shah, next topic.
Yeah, Omkar. Omkar, read it.
Yes.
A very classic appearance.
A young lady of 24 years present with repeated attacks of jaundice with low-grade fever with chills and rigor. Ultrasound scan showed a dilated CBD without any stones, not in the gallbladder nor in the CBD. What is the investigation that has been carried out? How does one classify this defect?
What is the investigation?
Sir, MRCP, sir.
Good. What do you see?
Okay.
Classic appearance.
Sir, there is dilated CBD, grossly
How is
dilated
the
DB,
dilatation?
and
Describe. It's not
dilated
a
pancreatic
dilatation.
duct.
No, it's a classic dilatation, not just the dilatation.
I mean, you have to describe the class dilatation. That's what Professor Shah said.
The confluence appears normal. The confluence appears normal. So how is the dilatation? Circular, fusiform.
Sir, fusiform dilatation of the CBDs. And sir, it could be
Find
Other
the
thing you
distal end.
need to
yes.
How do you find the
It's-
confluence? How do you find the distal end when the PD is joining?
Sir, it is distal end, sir.
So I've enlarged it now.
Yeah.
Sir,
Because your type will depend on this. Your type
yes,
will depend on your description. Next question is types.
sir, it is one choledochal cyst type 1B, 1C, sir.
No, describe the, you're right, but describe the, you need to describe what you're seeing out here. What is this part called?
Sir, ampulla. It's
This is the common pancreatobiliary channel. Okay, that's the pancreatic duct, isn't it?
pancreatic duct, it is dilated. Sir.
This is the common bile duct.
Yes,
So that's important because that's Professor Shah was saying. You're going to have to classify this. So how do you classify? This is what type of a choledochal cyst? Which
Sir,
classification do we normally use? What is that? Goes by a name.
sir, Todani-Alonso-Ledge classification.
One is modification of Alonso-Ledge.
Yes.
Yes. So what classification is it? You're right. That's the Todani classification.
Yes.
Type 1, type 2 is a diverticulum, type 3 is a choledochal cyst,
Choledochal.
4A is a saccular dilatation of CBD intrahepatic, type 4B is a saccular dilatation of only the CBD, and type 5 is Caroli's disease, but it has been sub-classified, and that is because you need to have a normal pancreatobiliary junction. What is a normal pancreatobiliary junction? That's the bile duct coming, and that's the pancreatic duct. You have a sphincter of the CBD, and you have a sphincter of the pancreatic duct, which is separate, that they combine out here, and then you have the sphincter of the ampulla. That's the correct normal pancreatobiliary junction. If you don't have that, it is important to classify them as per whether they have an abnormal pancreatobiliary junction. And type 1A, cystic dilatation of the common bile duct, as well as all of the common hepatic duct, extrahepatic portions of the left and the right hepatic ducts, are associated with an abnormal. You see, they are associated with an abnormal pancreatobiliary junction. Why? Why is it important? Because when you're excising it, you need to be very careful of not taking the pancreatic duct. Isn't that right, Professor Shah?
Yes. And that is also described as one of the etiological factors for development of this choledochal cyst.
Yes, absolutely. 1B is what you were trying to describe, absolutely right, but you need to, this focal segmental dilatation, often of the distal common bile duct. They are not associated with abnormal pancreatobiliary junction, which is what I presented. So you can do, you were relatively safer taking out the entire choledochal cyst and not having a damage to the pancreatic duct. 1C, smooth fusiform dilatation. Typically, the dilatation extracts from the pancreatobiliary junction to the extrahepatic portion. This is the extrahepatic portion. The left and the right hepatic ducts are normal. And this is also associated with the abnormal pancreatobiliary junction. And D is where you have a cystic dilatation of the common duct and the cystic duct as well. Again, 3 has 2 types. 3A, bile duct and the pancreatic duct enter the cyst, which then drains into the duodenum in a separate orifice. And you have a type 3B, where you have the diverticulum of the intraduodenal common bile duct or intraampullary common ductal channel. So there's a, not a different opening into the duct. And you of course know the classification of type 4. 4A is both intrahepatic and extrahepatic cystic dilatation, and 4B is multiple extrahepatic cysts, but no intrahepatic cyst. If you have a Caroli's disease, the only treatment possible is an orthotopic liver transplant. For others, you do an excision, but a complete excision. Why is it that we do a complete excision? Why is it important to take that entire common choledochal cyst out?
Sir, in case of Caroli's disease, sir?
No, in the idea is excision. Suppose type 1, type 2, excision is the treatment.
Yes.
What if you retain the bile duct by drainage?
There could be recurrent cholangitis.
Apart from this, more important is?
More important. This chronic infection leads to something.
What is the risk of
If you have
meningitis?
a chronic,
What is the risk of malignancy in patients that got colorectal cyst as a
Sir,
whole?
cholangiocarcinoma, risk of cholangiocarcinoma, more risk.
Yes. Next one, Professor Shah.
Take Milin can take.
Okay.
A 50-year-old Caucasian with ulcerative pancreatitis in remission presents with fatigue, disabling pruritus, features of episodic cholangitis with fever and chills and rigors, and recurrent right upper quadrant pain. He is found to be icteric, scratch marks, and tender hepatomegaly, and a just palpable spleen. The MRCP is presented. What is seen? What is the likely diagnosis?
Okay. Describe the MRC picture. Normal or abnormal?
Sir, it's not normal, sir.
Okay, fine.
I
What
see
do you
two
find?
areas of sir, two areas of focal dilatation in the CBD, sir, and along with that, there appears to be a disjunction, some kind of a discontinuity between the CBD and
One frame you cannot say this discontinuation. You have to see other frames
No.
also. But what do you find the distal CBD also? Is it normal?
no, sir. There is tapering of the distal CBD, sir.
Yeah.
Irregular tapering of the distal CBD, sir.
Something I'm pointing out.
So
Something I'm pointing out, Milind.
strictures,
there
sir.
are-
And
So there are multiple sites of.
Multiple sites of stricturing, sir, narrowing.
Yes. So this is classically found in a particular condition. Patient is having a classic history of ulcerative colitis. So what they have associated?
Oh, so,
so this is the possibility. Primary sclerosing cholangitis or a recurrent pyogenic cholangitis. But you remember what I said, the patient is Caucasian. There's somehow the RPC is stuck to people of our part, Asian and the Far East. Primary biliary cholangitis and multisite cholangiocarcinoma. So the question was, what is the most likely diagnosis? I think he's answered, Professor Shah, but just a bit is a disease characterized by severe inflammation, PSC, the etiology of medium and large biliary channels, leading to the intense fibrosis and stricture. So it's not the small channels that are affected. You see out here. Sorry.
Yes, sir.
I can't get it to expand. Yes. You see, there are multiple strictures, areas of strictures. You can see that's the left hepatic duct. There's a stricture at the junction of the left hepatic duct to the confluence. There's another stricture out here. There's possibly a stricture out here just above the cystic, where the cystic duct takes up. There's a stricture out here. There's another stricture out here, and that's your distal CBD. Yeah. So, therefore, appears more than 5% patients have ulcerative colitis and more patients with pancolitis. And patients with Crohn's disease are less likely to have it. What's the risk of a primary sclerosing cholangitis? Particularly, let's suppose this patient has ulcerative pancolitis. What is the risk? What is it that we are worried about?
Sir, if the chronic inflammation can lead to development of carcinoma, sir.
Where?
In this case, if from primary sclerosing cholangitis, it would lead to cholangiocarcinoma.
Yes, but which part? Cholangiocarcinoma, that's fine. But don't forget, these people have a 5 times higher risk of developing carcinoma of the gallbladder as well. So, which is why they sometimes present with a mass in the gallbladder. And so the lab findings are fluctuating bilirubin, ALP, aminotransferases are typically less than 300, hypoalbuminemia in the later stage, you have a hypergammaglobulinemia, high serum IgM levels, an atypical P anchor in 30 to 80%, and an HLA antigen which is positive can be high. But what is important is to differentiate it from primary biliary cholangitis mitochondrial antibodies are negative. Imaging may be normal, ductal changing, gallbladder, and this is why I'm trying to point it out. Have wall thickening, enlargement, calculi, cholecystitis, may even have mass lesion. So remember that one of the etiological factors for a gallbladder cancer is the existence of primary sclerosing cholangitis, particularly where the patient has ulcerative colitis. And this is what you find on a CECT, ductular changes, thickening, inflammation, saccular swellings, perihilar lymphadenopathy. Now, if the important thing is if you're planning for orthotopic liver transplant, the thing never to do is don't go in for an endoscopic ultrasound guided FNA of this area. Portal hypertension, varices. Now, one question. Suppose this patient has a florid pancreatitis and has primary sclerosing cholangitis. What is the operation? This patient has florid ulcerative pancreatitis and desperately needs surgery. So what's the type of surgery you would do for this patient with ulcerative pancreatitis?
There are total proctocolectomy
Okay, you've done a total proctocolectomy.
with the
That's the colon.
yes, sir, total proctocolectomy with
And
the
it's
ileal pouch, ileoanal anastomosis, creating a pouch.
I'm very scared that this patient might have residual, I do an ileoanal pouch, but I'm slightly worried about that part getting inflamed. So what are you going to do? I'm scared. I'm scared of having inflammation in this area. What other operation can I have done if the patient didn't have primary sclerosing cholangitis? Can I do a complete pan proctocolectomy and bring it out as a Brooks stoma and ileostomy?
And yes, sir.
No, you can't. Not in a patient with portal primary sclerosing. Why? Because you inevitably have huge varices developing around it, and the patient bleeds.
Oops.
So this is one indication for, as you quite rightly said, an IPA. You do an IPA, and that's one of the conditions. You try and keep that last segment under control. Okay.
Yes.
Right. So types of PAC, you have intrahepatic at 87%, intrahepatic alone in 11, extrahepatic alone. Cholangiocarcinoma is very difficult to diagnose. Insidious offset, often you have a worsening obstructive jaundice and an escalating CA19-9. Risk factors for cholangiocarcinoma and PSC is age, liver histologic stage, concurrent chronic ulcerative colitis, smoking, and a history of varicose bleeding. So the treatment is as follows: medical, you can use Yodca, you can use corticosteroids, cyclosporin, tacrolimus, methotrexate, azathioprine, and 6-month captopril. Antibiotics in combination, cholestyramine, phenobarb for pruritus, vitamin replacement. Endoscopic, if you have a dominant extrahepatic stricture, you can do an endoscopic dilatation, balloon dilatation, stenting, but you need to rule out a cholangiocarcinoma. Surgical biliary bypass, orthotopic liver transplant, proctocolectomy only indicated for ulcerative, but IPA preferred over Brooks ileostomy because there's a high incidence of peristomal variceal bleeds. Okay, we go to the next one, Professor Shah. Who's going to take this one?
Sir, I'll go.
Okay.
An 83-year-old presents with painless progressive jaundice with high-colored urine, pale stools, and pruritus. he presents to you with this CT scan. The CT scan shows a
But
dilated.
what sort of, answer the first question, what sort of jaundice does he
Oh,
have?
sorry, what sort of jaundice does he have? He most likely has a surgical jaundice because of high colored urine and pale stools along with pruritus.
Stool and pruritus. Why does he have pruritus?
So the pruritus is because the bile salts get deposited in the dermis and irritate and cause histamine release, which causes pruritus.
Do you know the pathways along which this the you know the sort of reaction happens? Do you know the pathways?
No, sir, sorry.
They're essentially evidence-based has proved there are two pathways. You know, if you're doing very well, then you're going to get asked that. You have
Okay.
from the skin, you have cerebrospinal pathway up to the cortex. Okay. And there's another one called the Cowhage, Cowhage, Cowhage pathway. Cowhage is an irritant sort of a weed which is found at the seashores. That utilizes another separate channel that's called the Cowhage pathway, which is why it's very difficult to treat these pruritus with medicines alone. It's not the single thing.
Okay.
So what do you see on that image?
So the image shows a dilated CBD along with mildly dilated intrahepatic biliary ducts. The peripolydocal area is also inflamed.
Sorry? Yes,
The
Malavika?
pericolydocal area also seems a pathological.
Let me do something. Let me just, I'm going to dilate that segment. Okay. Now you tell me where it is. That's the bile duct,
Yes, sir.
isn't it?
Yes, sir.
What is this?
So there is an inflammatory structure.
I wouldn't use the term inflammatory. There's, what is this called? Would you call this shouldering, for example?
So, shouldering, sorry.
Okay. Isn't that shouldering?
Yes, sir.
So if you have shouldering, what are you now going to be thinking about?
Most likely malignancy, sir.
Okay. So what sort of cancer?
Cholangiocarcinoma.
That's a cholangiocarcinoma. Yes. So, so you see a area, a short segment of narrowing, which is situated in the lower end of the bile duct, probably inside the pancreas, the head of the pancreas. And you see that this is a guy who's coming with shouldering as a classic shouldering out here. So most likely cause is a cholangiocarcinoma. So how is the disease classified?
I don't know, sir.
Okay.
Oh, intrahepatic
Bile
and
duct
extra.
cancer,
Oh, sorry.
intrahepatic, hilar, and extrahepatic. Unfortunately, for weird reason, I don't know why, intrahepatic ones are called the primary or the peripheral tumors, because supposedly the first people who described the cholangiocarcinoma described extrahepatic. So the liver intrahepatic one became a peripheral. So that's a classic peripheral cholangiocarcinoma, hard, compact, grayish, massive nodular lesions are found in the liver. This is PET sensitive. Extrahepatic ones are not very PET sensitive because their growth rates are slow. So the TNM classification, and I'm not going to give it because it's quite extensive, classifies them separately as intrahepatic, perihilar, or distal. So intrahepatic has stages. It's often a diagnosis of exclusion, liver mass, cytologically for adenocarcinoma, extensive search for primaries unrewarding. You have a mass forming, you have a periductal, spicular forming, and an intraduct type variant of these are intrahepatic. But you have something called the bismuth-Paulet staging of hilar cholangio, of hilar extrahepatic cholangiocarcinoma. Sorry, guys, that should be extrahepatic. You have a type 1 where it's below the confluence, a type 2 where the confluence is involved, and sometimes that goes by the name as Klatskin tumor. Okay. You have a type 3A, where the carcinoma extends into the right hepatic, and a type 3B, where it goes into the left. And then you have a type 5, where this is the classic Klatskin, where you have the tumor extending from the bile duct into the right and the left hepatic ducts. And you have another variant where you have separate multicentric cholangiocarcinomas. So you must read the AJCC's 8th edition staging, separate staging for intrahepatic, perihilar, and distal. Now, how are you going to manage that? You assess for resectability, and that has been somehow neglected. The traditional guidelines are absence of retropancreatic and paracecal nodal metastasis or distant liver metastases, absence of invasion of the portal vein or the main hepatic artery. So although some centers would do an en bloc resection with a vascular reconstruction, absence of an extrahepatic adjacent organ invasion, and absence of disseminated disease. This is the traditional guidelines. But the unfortunate thing is none of the classifications assess for resectability. Most large CLVs, 32% were found unresectable, 29% found to have secondaries at exploration. Therefore, a staging system has been proposed based on staging laparoscopy with ultrasound. And distal tumors usually need a pancreatic duodenectomy, like this patient who's come in. Longitudinal breast spread is less than pancreatic tumors. True mid-CVD tumors, difficult to define. Only independent predictor of long-term survival is the number of lymph nodes, the lymph node status, and the depth of invasion of the tumor. So this is the Janarkin, quite a famous hepatopancreatobiliary surgeon from Europe, and that was the staging. So T1 is involving bilateral confluence with plus minus unilateral extension to the two biliary radicals. No involvement of portal or hepatic vein either way. T2 is involving the biliary confluence and the unilateral extension to biliary radicals with ipsilateral portal vein or hepatic plus minus hepatic artery. T3 is involving bilateral with extension to biliary radicals, and none of these facts are available. So that's T3, which means that they haven't been staged. In B grade, it's involving the biliary confluence with or lobar hypertrophy, and involving biliary confluence not available. So you see, it's not a very robust classification, but just to tell you, Bismuth Collet type 1 and type 2, you have an en bloc resection of the extrahepatic bile duct and gallbladder with histologically creal margins and a regional lymphadenopathy, lymphadenectomy with Roux-en-Y hepaticogenesis. It's mandatory to send the end of the cystic duct for a frozen section, because you need to, sometimes these patients have longitudinal spread. In a type 3, you do an en bloc resection of the extrahepatic bile ducts and gallbladder with histologically clear margins. But see, because you're resecting that, you have to remove the caudate lobe of the liver, because the spread goes through the caudate lobe with the regional lymphadenectomy with Roux-en-Y hepaticogenesis. Type 3 and type 4, again, same. I would say it always requires removal of the caudate lobe of the liver, because don't forget, the caudate lobe is when you have posterior spread of the lymph nodes from here, that actually traverses the caudate lobe. So you have to remove the caudate lobe with a Roux-en-Y hepaticogenestomy. And then so this is the sort of a flow chart, which you do a triphasic CT scan and MRCP, RCP or PTC or MRCP, find out whether the patient is resectable. If the patient is resectable, and then must resection of bile duct with hilar nodes, peripancreatic and retropancreatic nodes, often may need segmentectomy. Often, as we realize, they need a removal of the caudate lobe. Often, if there's no extrahepatic spread, there's a very, very fine definition. They might need orthotopic liver transplant. If it's irresectable, you have various types of surgical bypass or surgically placed catheter, percutaneously placed catheter with internalization, and endoscopically placed catheter. So, Professor Shah, we have 6 minutes left. Shall we take questions or go for the next one? Professor Shah?
Sir is connected, but he's on mute.
We can take one more scenario. Last
Okay.
one. Yeah.
Somebody take this away from me.
Nitesh?
Yes, sir.
Yeah, please. This is a CT scan.
Yes, sir. So 46-year-old who runs a sheep farm presents with discomfort in the upper left quadrant and early satiety.
Sorry, it should be the, yeah, okay, but that's an epigastric region, yes. And early satiety, yes.
So he has been suffering from longer than 8 months. The ultrasound scan shows cyst in the liver. The CT scan is presented. What do you see?
Describe the CT scan finding. It's close to the stomach. So it might be in the left lobe.
Left lobe of the liver, sir.
What do you see? How is the classic appearance of the cyst? Describe the cyst. How did it come next?
First, you have to describe.
Sir, the outer margin border is, sir.
So that's the border. You see
Yes,
something out here. What is that? Start from the periphery. First, the location. It's located in the left lobe of the liver and pressing on the stomach, which might explain the patient's early satiety. Okay.
Yes.
Number one. So that's number one. Then you start describing the lesion.
Sir,
it's an irregular lesion or a regular lesion?
Sir, it is regular, sir.
Okay. Now it's a regular lesion. And you take the periphery. What do you see in the periphery?
Sir, ectocyst, sir.
No, hang on. Don't start with the ectocyst. I'm pointing something out to you. What is this?
Sir.
If this is seen in a plain CT?
Sir?
See, look at this. What is this structure? What is this structure?
Yeah.
What is this structure?
Just behind the liver.
What is this structure? Can you see my cursor on that?
Yes, sir.
What is this structure? Behind this white structure, and this is the stomach. So what is this?
Big vessel in front of the vertebral body. What is that?
Sir, sir, aorta. Sir,
aorta, yes. So do you find any dye in the aorta?
No, sir.
So is this a plain CT scan or a contrast CT scan?
Sir, this is sir, plain CT scan, sir.
Plain CT scan.
Therefore, stomach you find some contrast. It's a oral contrast given.
Yes, sir, oral contrast given. Sir.
IV contrast has not been given.
Yes, sir.
Okay. So now I'm pointing this out to you. In a plain CT scan with oral contrast, I can see this. What is this?
Sir, calcifications.
Calcification in the wall of the cyst. Quite right. So we've described the calcification. The cyst appears intact, but with the edge shows a calcification, isn't it?
Yes, sir.
Now go inside. What do you see? Is it a uniform unilocular cyst?
No, sir. It is multilocular, sir. Uniform, sir.
Okay, so it's not just multilocular. There's some thickening out here. Can you see these thickenings?
Yes, sir.
Okay, so you have to describe this. You know, if you don't describe these, people are going to say he knows from before.
Yes.
I know. So during an examination, you need to describe it. That is what Professor Shah is trying to tell you. So you can see that they are thickening, that they are not just septate, multiple septate, almost like a honeycomb with thickening. I can see thickening and I can see that calcification.
Yes, sir.
There are no other cysts in the liver. There are no other cysts out here.
Yes, sir.
So now my first diagnosis is, and now you come on and tell me.
Sir, diagnosis is, sir, hydatid cyst of the liver, sir.
Okay, so what stage? I mean, I expect something more from you because I've seen this calcification and I've seen this thickening.
Yes, sir. So C.
So is this a very active cyst or an cyst showing periods of inactivity?
If you have
C.
calcium indicates what? It says
Sir, it is inactive cyst. Calcification cyst is inactive, sir.
So it's not completely inactive because there are still a fair number of cyst-like structures. It's a cyst, it's a hydrated cyst, which is showing signs of inactivity. Okay. So
Yes, sir.
given the fact that it shows inactivity, I'm going to preempt the classification and I'm going to ask you, what are you going to do? It shows signs of inactivity.
Yes, sir.
But it's more, the size is more than 5. This is 5 centimeters. You can calculate that this is actually more than 5 centimeters.
Yes, sir.
And is it situated deep inside the liver or right at the surface?
Sir, right at the surface, sir.
Yeah.
Now you tell me it's situated in the left lobe, right at the surface. It shows some signs of inactivity. So how would you manage this patient?
Sir, size.
Sorry?
Sir, cyst size is, sir, larger, and sir, symptoms of
in terms of stomach compression. So
yes, stomach compression has that, sir. Sir, we'll go for, sir, surgical management, sir.
You have to, it's a must to go for surgical management, because otherwise this patient cannot, what is the risk? That might rupture. And that's the worst thing,
Yes.
that it's partially active. If it ruptures, you
Yes.
have disseminated hydatidosis, and that is
Yes,
really difficult to control. Okay.
Yes.
It's
Yes,
situated
sir.
in the left lobe, right at the surface. You can't even do a pair. You can't do a pair because it will leak.
Yes, sir.
And it is pressing, Professor Shah quite rightly pointed, it's pressing on the stomach. This patient can't eat. It's a farmer. He's used to having a very good lunch of a lot of rice and in the afternoon and at night. He can't eat. He's losing weight.
Yes, sir.
So the other question is, how is it classified? You have an ultrasound international working group classification, and this is the WHO International Working Group of Echinococcus classification. You have a cystic lesion that is CL, CE1 and CE2. This is a unilocular hydatid cyst. You have a multilocular hydatid cyst out here, but it is active. There's no thickening. The moment you have some amount of things, so this is classically described as a transitional
Yes, sir.
hydatid cyst, isn't it? Because you had a bit of thickening, just like you have out here. You had thickening out here. Okay.
Yes,
So
sir.
this is transition. C4 shows heavy calcification. Now, if this cyst was present deep in the liver, less than 5 centimeters, showing signs of inactivity, you may get away by treating this patient with what medicines? What oral medicines to be used?
Sir, we'll go for benzimetazoles group of drugs like albendazole, mebendazole, sir.
Okay. What dose?
Dose, sir, sir, 400 albendazole, sir, 400 milligram BD for 3 to 8 weeks, sir.
Okay. But what do you need to do if you have a patient on such a high dose of albendazole? You need to do some regular blood tests.
Sir, we'll do, sir, LFT, sir.
Yes. Okay. Right. So I think Professor Shah, do we want to go to the next one then?
no, we will do another class next one,
Okay.
including pancreas. It
Because
is
I
very
thought I'd be covering most of, because I've got a fairly large segment on liver as well. So,
yeah.
And then we'll go down to the pancreas.
Okay, sure, sir. Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you, Professor Shah.
Thank you. Thank you.
Thank you, sir.
Welcome. Thank you.